Okay, so this one is going to be about junctional and idioventricular rhythms. The easiest way to identify junctional rhythm is that it looks regular. It's normally pretty slow, between 40 and 60 beats a minute, and there's no P wave. It just drops into the Q. That's the big one. You'll never see a P wave in a junctional rhythm. So some people will go like, oh, that's sinus Brady. Nope, no P wave. So can't be. That's it. Uh, the QRS is often kind of wide. Like, look, the Q. What? Why does something pop up on my screen? Okay, hold up. Okay. The Q is here and the R, but look how wide the S is. So the QRS is from there to there, which is, I don't know, it's more than 3 boxes. That's really all you have to know. And then let's see. Yeah, oh yeah, this is good. Yeah, sometimes a P wave will occur, but it won't actually trigger a QRS. It can happen inside of this and make this look funky, which is maybe what's happening there. Because see how it kind of like whoops out. And then sometimes you'll see it after the QRS, which is just not very helpful at all. There's another example of a junctional rhythm. Remember, it's going to be between 40 and 60 beats per minute. Next is accelerated junctional rhythm and junctional tachycardia. This just means that it's faster. It's junctional, but it's faster than 60 beats. So the accelerated, sorry, I got something crappy in my throat. The accelerated rhythm will be, it'll be like a normal rate and rhythm when you think of sinus, but it's accelerated because it's junctional, no P wave, and it'll be between 60 and 100. And if it is greater than 100, it's called junctional, junctional tachycardia. So no P wave and the rate is greater than 100. And I don't know, I haven't really been talking about the treatments for these because I feel like this is just about EKG interpretation. But for this, they will give a beta blocker or an IV amiodarone to try to get it back into rhythm. Beta blocker will slow it down, and sometimes that's all you need for the P wave, for the SA node to be like, I'm here. Okay, first degree AV block. This is basically normal sinus rhythm, or any of the sinus rhythms, because it could still be, Brady or tachy. A lot of times it is Brady. But the P wave, let me get a little marker here, one that I can see, is way out here. So the distance between the beginning of the P wave and the beginning of the QRS is going to be greater than 5 boxes. QRS will still look normal. It'll just be that there's be a big space between the beginning of the P wave and where the QRS is. See how many boxes I've colored in there? If it's greater than one of these big boxes, you already know it's too big. That's how you do it. Down here is a couple of examples that really show it off. So way out there from here to here. And that's like 5, 6, 7, that's 8 boxes. So you're at, I can't do math, but yeah, too many. And then this one is as well. It will be regular. The QRSs will be regular. The P waves will be regular. They will just always kind of be too far away from the QRS. So that's first degree AV block. Oh, and I should probably mention that this is normally asymptomatic, and people can have this forever and it not cause any issues as long as it doesn't change into a second degree AV block. It's just slow conduction. Okay, second degree AV block has 2 different types. Type 1, which is known as Mobitz type 1 or Winky-Bach. There's like a little video that they did to Justin Timberlake's song, I'm Bringing Sexy Back. And there's a video like on YouTube that I think they were medical students did like 15 years ago, but it's really good because it does show you exactly what's happening. So I'm going to start I'm going to start here. Okay, so this one, that's a normal PQRS. See how close the P wave is? Oh, sorry. See how close the P wave is to the QRS? So, looks normal. And here, oh, it's backed away a little bit. So, that's weird. And then here, it's backed away a little bit more. And then a little bit more. And then it's backed away so far that it skips a beat. So, you'll notice that the QRSs stay pretty regular. But the P to P just gets closer and closer until it drops a beat, and that's Winky Bach. The QRSs will normally look normal, and it's always evidenced by the P wave changing its distance through several beats, and it can take. Sometimes it's like every 1 or 2 or 3 beats, and sometimes it's like 5 or 6. Just depends on how fast it's moving out. This is also something that they just normally watch and don't necessarily treat, but it can lead to type 2 MOBITs, which is more dangerous. So that's the thing to watch out for in this one. I'm sorry if sometimes I don't even have what I'm talking about on the screen. I kind of forget to pay attention. So second degree MOBITs, I'm not real sure why they have this picture here. I guess because it's in every other one. So if you look at it, there's a QRS, a T wave, and there's a P wave, but no QRS. And then same, P, QRS, T, P, bloop. And I think there might be a better example of it at the bottom of the page. So this is, normally when you see this, you'll see 3 or 4 beats that look pretty normal, and then you'll just see a P wave like at the correct distance, but nothing, it doesn't trigger any ventricular contractions. And that's why this is a more dangerous heart rhythm, because it can have several beats in a row where you don't have a QRS. So it's, the ventricle is squeezing, pew, 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 and then it's like, and the atrial is still trying, but the ventricle is like, nah, I need a minute, and then it comes back in. And this isn't necessarily in a regular pattern. It's just going to be the dropping of beats. The difference between this one and Winky Bach is that the P wave, PR interval is always the same when it actually fires into a QRS. And this can a lot of times cause some issues with the patients who have this are not always symptomatic, but a lot of times they are. And if they become symptomatic, a lot of times what they need is just a pacer to start pacing those extra beats that are missing. And they'll start off with the kind that they put in through the groin and go up to the heart and make it squeeze. And then they'll have them on that until they stabilize, and then they can put in a permanent pacemaker. All right, and this is one of the 3 deadly rhythms. It is third degree block. And a lot of people have trouble with this one, but to me it's one of the easier ones because it's very regular. It's just not coordinated. So if you look at the QRSs, they're very regular. Boom, 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 boom. And if you look at the P waves, boom, 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 boom. They're also very regular. If you measure out, like this one kind of got lost in the QRS, but there's one there. So if you measure that out and then go to the next one and go to the next one and go to the next one, they're equally spaced, but they are not coordinated. So the P wave is, the atrium is like, come on, man. And then the ventricle is like, I'll get to it. So a lot of times with this, you'll see a really slow rate because the ventricle is beating, the ventricle nodes, the AV node, it always fires less than 60. Like 20 to 40 is pretty standard. So the ventricular beat will be slow, and the P beats will be, those are the atrial beats, they will be normal most of the time. But yeah, just not coordinated. This almost always leads to a bad outcome if you don't fix it. These patients get just like the last ones that we were talking about, these patients are almost always symptomatic. And even if they're not, we're going to put a pacer in them because they're going to get symptomatic. So yeah, they'll put in like a temporary pacer and then upgrade to a permanent pacer when they're stable. And and see how wide the QRSs are? That is very symptomatic of that's going to be a ventricular, like an AV node is firing to make that happen. If you've got a wide QRS, that's what that means, is the beat's not coming from the atria, it's coming down from below in the AV node, and so that's why it's slower and wide. Here's a couple more examples of the third degree. And this is just showing, like, this patient has AFib, so they're having an atrial, fibrillation, boop, 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 and then their ventricle is like, the AV node's like, I'm doing my thing, but it's just real slow. There's no obvious P wave or distance measurable. And then down here, this one, some people would confuse it with type 2 Mobitz, because it kind of looks like, there's a ventricle, I don't know, maybe a T wave, a P wave, another P wave, but that's, if you look at it really close, you can see that the P waves are getting lost in this QRS, and so it's really still regular. Can you see that? Yeah, my purple's not super great, but so regular P and regular QRS, but not coordinated, third degree. You can give these patients atropine to help speed them up until you can get a pacer in them. Okay, and then PVCs. PVCs are just like an atrial, premature atrial contraction, except for these come from the ventricle. So they'll have whatever their underlying rhythm is, just boom, boom, boom. It could be AFib, it could be A flutter, it could be normal. It doesn't really matter. And then the ventricle gets real excited and is like, I'm going to go right now. And so it just gives an extra beat. They always look weird. Remember on the PACs, the QRS was still normal. It was just kind of early. On the PVCs, it's always going to be this wide, complex, really Q to T kind of situation. And then they can also have them where they're multifocal. Like this is monofocal, because see how this one, this one and this one look the same? That's going to be coming from the same origin point. That's a lot of patients have these, and once again, they're completely fine. The only time they're not fine is if they become too frequent. Like you may have heard of the term run of PVCs, and it's where they'll be beating in their normal rhythm, and then all of a sudden it'll be like boom, 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 and it'll be 5 or 6 of these in a row. And we call that a run of PVCs, and that can lead to VTAC, which then goes on from there. And here there's a multifocal. Because I was going to say this is unifocal again. If you look, same. And then these are the actual real beats that are actually doing something and coordinated. And then the multifocal, they'll be really wide, like these guys, but they won't look the same. So that's coming from one part of the ventricular area, and this is a beat that's like being born in a different part of the ventricular area. PACs can do the same thing. It'll just be on the atrial side instead of the other. Let's see what else we've got in here. We may be almost done. Yeah, that's an AFib with PACs. And this one actually, if you ever hear like bigeminy or trigeminy, that's what they're, and it goes on from there, but that's what this is. It's whenever they have, it's in a pattern. 2 regular beats and then a PVC. 2 regular beats, PVC, and it'll be repeating like that. And, sorry. So this is bigeminy because there's 2 beats and 1. 2 beats and 1. And I'm going to see if they have any other examples while we're here. Nope, they don't. So trigeminy would, let me see if I can, so it would be like, and I'm not going to do the whole thing, but normal beat, normal beat, normal beat, PVC, normal beat, normal beat, normal beat, PVC. So see, that's terrible, but that's what trigeminy looks like. And there's another thing that's called couplets, and that is when you're like having normal beats. They should be much thinner than that. I'm making them far too wide. But then you have 2 PVCs in a row, and then normal beats. So that's what we call the couplet, is whenever you've got a regular pattern. You've got like normal beats and then two together, and then normal beats, two together. So, anywho, I'm going to do the last ones on a different video because this one was kind of long.